Well, good afternoon, everyone. It's 12 o'clock, so we're going to go ahead and get started. Welcome to our cardio webinar, COVID-19 and Cardiovascular Health, Managing Patients and Incorporating a Telehealth Framework. I'm Dr. Michael Constant, and I'm pleased to serve as the Principal Investigator of the Ohio Cardiovascular and Diabetes Health Collaborative, also known as CARDIO, at Case Western Reserve University School of Medicine. Joining me today is Dr. Sherry Bolin, Co-Principal Investigator of CARDIO, also from Case Western Reserve University. Founded in 2017, CARDIO's mission is to improve cardiovascular and diabetes health outcomes and to eliminate disparities in Ohio's Medicaid population. CARDIO brings together Ohio's 7 medical schools to identify, produce, and disseminate evidence-based cardiovascular and diabetes best practices to primary care teams. To learn more about our collaborative and to access our online repository of best practices, please visit our website, cardio.org. I would like to acknowledge and thank our sponsor, the Ohio Department of Medicaid, and our administrative partner, the Ohio College of Medicine Government Resource Center. And I also like to recognize the partnership of Ohio's 7 medical schools who contribute to make the CARDIO Collaborative a success. And now I'll turn today's webinar over to Dr. Bolin.
Thanks, Mike. Just some brief logistics. If you're joining as a group, please use the Q&A feature just to record your names and emails of all the attendees in the group with you. And if you have questions throughout the webinar, again, use the Q&A feature to submit questions at any point, and we will answer those during the Q&A portion of the webinar. We will have an evaluation survey that we'll have at the end that will be shared at the end of the webinar when it closes off and also sent by email. And we'd love feedback on that by the end of Wednesday, November 23rd next week. This is just sharing with you that we don't have any conflicts of interest from either the speakers or our planning committee. And for those of you who want continuing medical education, we are offering that. We will send a separate CME evaluation, probably closer to the end of the week or next week. And we'll give you several weeks to fill that out. If you don't get an email survey around CME, just contact Kathy Sullivan here. And if you are not registered, you do need to register to get CME credit. So if you aren't registered for some reason, you can use the QR code or the link that was just sent in the chat to register for this. And here's our wonderful agenda for today. We'll have our main speaker, Dr. Singh, who Dr. Zack will introduce momentarily, and then some Q&A. With that, I'm going to introduce Dr. Amy Zack. She is a family physician and vice chair of education at Cleveland Clinic, and also faculty at the Case Western Reserve University School of Medicine. Dr. Zack serves as the head of education dissemination for CARDIO and helps us with all of our webinars to disseminate. So thank you so much for helping us get this set up, and I'll let you introduce our speaker and moderate for us.
Thank you so much, Sherry. It is my pleasure today to introduce our speaker, Dr. Tamanna Singh. Dr. Singh is the co-director of the Sports Cardiology Center at the Cleveland Clinic and assistant professor of medicine at the Lerner College of Medicine at Case Western Reserve University. She earned her medical degree from Boston University School of Medicine, completed residency at Boston Medical Center, and then her cardiovascular medicine fellowship at Icahn School of Medicine at Mount Sinai in New York. Additionally, she returned to Boston and completed specialty training in sports cardiology at Massachusetts General Hospital. As a sports cardiologist, Dr. Singh provides cardiovascular care for professional sports teams, competitive and recreational athletes, and highly active individuals. She has significant experience in cardiopulmonary exercise testing, and over the last couple of years has developed an interest and expertise in studying the post-acute sequelae of COVID infection, formerly known as long COVID syndrome, with a particular focus on athletes and active individuals. She routinely evaluates patients with this post-acute COVID through the dedicated Recover Clinic at the Cleveland Clinic, which is a multidisciplinary center focused on providing care for these patients. So please join me in welcoming Dr. Singh.
Thank you so much for that wonderful introduction, and thanks so much for having me here today. I'm very excited to talk about something I think pre-2020 none of us would have even known about. So I really appreciate being here and spending an hour together. So some of the objectives that we will have during our discussion today are just to first identify cardiovascular complications of COVID-19, talk a little bit about how to screen and treat patients with cardiovascular complications specifically, and then how we've been utilizing telehealth with post-COVID patients as a means of managing cardiovascular care. I think for the most part, many of us are very well in tune with how many coronavirus cases we've actually had. And it's actually quite staggering to think we're about to enter year 3 of this pandemic, or perhaps maybe close to this post-pandemic era. We are already past the 6 million death mark, and over 600 million cases, which is quite impressive, just to kind of develop and understand what the impact really is on our population. So with respect to the United States, I just wanted to bring about, what our trends have been. This is directly from our CDC website here, and you can see the staggering increase in cases over the December 2021 to early 2022 period, which basically kind of consists of, the number of cases being correlated to Omicron, and then of course the BA2. And this just shows you the ebbs and the flows of viral replication and viral infection within our population. So we'll talk a little bit about cardiovascular pathophysiology. And so what we're now starting to understand is that the basic pathophysiologic mechanism with respect to even cardiovascular and multisystemic complication is predicated upon cytokine storm. And that precipitates endothelial dysfunction as well as inflammation, or a process called endotheliitis. And endotheliitis in itself leads to a lot of release of prothrombotic markers and microvascular thrombosis. And we've seen this from a multi-organ level. So not just from a cardiovascular perspective or vascular, but also within our own pulmonary vasculature, as well as our splenic systems, our hepatic system, and whatnot. And then all of this kind of culminates to possible multi-organ organ failure with significant coronavirus infection. And this illustration on the right just allows for us to see kind of just the monstrosity of damage that we can see with significant COVID infection, as well as the mechanism. What we do know is that there is this outer membrane spike protein, or the S protein, that we've talked about since probably about maybe mid-late 2020, that has a high affinity to our ACE2 receptors. And these ACE2 receptors are present on many different tissues. And from a cardiovascular perspective, we see that presence on the myocardium. We see it on our vasculature as well. And basically, this membrane and this binding to the receptor correlates to the kind of hyperinflammatory state that we have, this prothrombotic state, as well as heightened vasoconstriction, fibrosis, and then the sequelae that come from that. I think preliminarily there had been this initial curiosity and concern for individuals who are on ACE inhibitors and angiotensin receptor blockers, and whether or not these patients were, in kind of a position where they could not tolerate those medications because of the viral infection. And we never really saw a correlation between treatment with ACEs and ARBs being associated with a higher incidence of COVID-19. So that was a theory that was debunked relatively early on in the pandemic. In terms of cardiovascular complications associated with acute COVID-19 infection, we've actually seen quite the gamut. The initial thought process was that viral myocarditis was going to be something that was more common than not. And I'm so happy to see that the actual incidence of viral myocarditis is really less than 1%. And particularly in a population that I'm interested in, athletes, it's well under about 0.6 to 0.7% of the competitive collegiate and professional athletes that we've studied. But at least back in early 2020, there was an initial thought that there was direct myocardial invasion by the SARS-CoV-2 infection. And we initially had seen about 100 patients with acute heart failure where endomyocardial biopsy showed that there was actual SARS-CoV-2 genome in the myocardium. And there were features of myocarditis present as well, meaning inflammation within the myocardial tissue, evidence of microvascular thrombosis, as well as myocardial necrosis. Autopsy data at the time also showed, and this of course was a very small study looking at 39 cases. Interestingly, there were 24 that had RNA present in myocardial tissue, but not all of them did. There were about 15 that did not have RNA. And so therefore, what they were able to determine was that the presence of SARS-CoV-2 in cardiac tissue was actually not associated with cell infiltration, or what we typically would see with myocarditis. And there was actually then no clinical myocarditis identified. So I bring that up to say that we do see viral infection of the myocardium, but we've also seen lack of viral presence within the myocardium. And so there is some discordance with respect to what's actually going on with viral replication and actual integration into the myocardial tissue. And we still don't really know what those long-term effects of viral activity within the myocardium are. In terms of cardiovascular manifestations from a myocarditis perspective, we have seen elevated troponin levels in acute infection that typically increases our suspicion for a higher incidence of myocarditis, especially when we've ruled out more type 1 MIs. The reality is, as I mentioned, is quite rare, and we've had still very few cases of fulminant myocarditis and cardiogenic shock. What we have seen are that arrhythmias are a more common manifestation of the virus. But again, kind of the frequency, the incidence are still relatively up in the air, because we have a whole kind of pile of data from early on in 2020 that is not necessarily the most reliable, since we were not able to catch as many cases. I think the numbers of the incidence and the prevalence are actually probably going to come out later, this year into early next year, as we're, articulating or I should say, as we actually have the ability to kind of get a better sense of what the numbers are. Early on, I think it was just very hard to track individuals coming to the hospital or staying at home. And that's why the incidence is just not well pronounced. So, I kind of just laid out that viral myocarditis does not seem to be the #1 cardiovascular complication with COVID. So what really does cause myocardial injury? So systemic inflammation is really the main culprit, and we are seeing a lot of thromboembolic phenomena. As I mentioned, arrhythmias are also one of the top cardiovascular complications. And then we still can't, completely rule out coronary plaque destabilization. A lot of times people will come in with COVID infection and we will see a type 1 MI or a STEMI or acute plaque rupture. And then, of course, most commonly, we see oxygen supply demand mismatch with our type 2 and STEMIs, as well as stress-induced cardiomyopathy, otherwise known as Takotsubo. Vascular complications are definitely something that we have encountered in our cardiovascular and vascular medicine clinics. And this is related to that hyperinflammatory prothrombotic state and endothelial dysfunction, preceding all of that. And this figure here, I think, is a wonderful depiction of how viral integration, attachment to the receptor, replication leads to the activation of macrophages, endothelial activation, as well as this prothrombotic state, leading to essentially multisystemic thrombosis. In terms of those who are at increased risk of thromboembolic disease, it's typically kind of the main comorbidities that usually heighten our suspicion and heighten kind of our understanding of risk stratification when patients come in with COVID. So the potential for increased risk is typically with those who are of older age, those who are bedridden, not moving around too well, those who already are showing signs of endothelial damage and vascular dysfunction, as well as any individual with hemostatic abnormalities and whatnot. And that's typically what we're going to see associated with increased risk of death or further severe cardiovascular or multisystemic complication. In a lot of these individuals as well, the question is, do we actually anticoagulate them or not? And by guidelines, we really don't have the data to support, kind of systemic anticoagulation. It typically is kind of provider dependent, but we do see in those who do have more severe infection, who are already showing evidence of either microthrombi or macrothrombi, perhaps these are individuals where we should consider DVT prophylaxis. As a cardiologist, we were, always thinking about drug interactions, particularly in our individuals who already have coronary artery disease. And, when we were utilizing ritonavir, lopinavir as treatment strategies for COVID-19, we had to do a lot of thinking and understanding of how this would impact dual antiplatelet therapy. So using medications such as clopidogrel, Anticoagulor, or Plavix and Brilinta from kind of a brand name perspective. And you can see here that, those types of antiviral medications do actually impact both clopidogrel and ticagrelor with respect to reducing clopidogrel activity or increasing the effects of ticagrelor. And so we were trying to be very cognizant of how we could utilize DAP safely in these individuals we were trying to treat with antivirals. And then there are, of course, potential drug interactions between anticoagulants as well as the investigational therapies we were utilizing. For instance, we would have to adjust vitamin K antagonists, Coumadin, apixaban, betrixaban dosing with these antivirals. We were avoiding things like rivaroxaban and reducing doses of our DOACs and vitamin K antagonists if azithromycin was being utilized. So, a lot of this was kind of more so early on or mid, kind of the brunt of the pandemic. I think, nowadays we're not necessarily concerned about dual antiplatelet therapy because, again, our viral severity, the number of people who are currently infected, fortunately, will continue to dwindle down. But these were definitely some of the initial thoughts that we had to consider. So, I kind of alluded to this with respect to, is there a role for empiric anticoagulation? It is, as I mentioned, provider dependent. I think at least in my personal practice, and I speak anecdotally, I think if someone is obviously coming in having had a history of a COVID-related thrombotic, whether it be arterial or venous thrombotic event, I'm definitely going to be, probably having a lower threshold to go ahead and start anticoagulation. I always incorporate my vascular medicine consultants when it comes to doing further investigation, perhaps of hypercoagulability that may be unrelated to COVID. So we definitely want to flesh out a patient's history and truly delineate whether or not any benefit of prophylactic anticoagulation does outweigh the risk of bleeding. With respect to acute coronary syndromes, the process again is kind of mainstay with respect to infection leading to a hyperinflammatory state, ultimately endothelial dysregulation even at the coronary level, and then plaque destabilization and rupture. So I'm alluding to type 1 MI here, not so much the supply-demand mismatch with type 2 and STEMI. So the incidence is still relatively unknown. I think the numbers kind of sometimes fall between a 9 to 11% in several studies. However, again, we kind of missed the mark with respect to those initial groups of patients who may have been having heart attacks at home, but were not coming to the hospital due to fear of contracting coronavirus. And so because of that, I do think our data is lagging behind. And again, the ebbs and flows of the pandemic also kind of are a confounder with respect to really truly understanding the incidence of type 1 MI with COVID-19. With that, early on in the pandemic, we did have delays in catheterization, whether that be here at other centers, particularly while waiting for test results, albeit STEMIs were always prioritized over NSTEMI. With respect to type 2 MI, there were definitely several suspected mechanisms. Obviously, you can have a type 2 and STEMI just in the setting of sepsis or septic shock. But from a cardiac perspective, this could have just been related to native fixed coronary atherosclerosis, or just, relative kind of stable non-obstructive or obstructive disease limiting myocardial perfusion at the time of infection. As well as some elevated circulating angiotensin II levels, vasoconstriction, severe systemic hypertension can also precipitate type 2 MI, endothelial dysfunction, as well as coronary microvascular disease could lead to type 2 MI. And then, of course, from a cardiopulmonary perspective, any sort of ARDS or pulmonary vascular thrombosis could also provoke hypoxemia, which would then lead to a type 2 MI picture. So, thereby we saw a lot of patients and continue to see a lot of patients with active COVID-19 who have troponin elevations. And the question is, are those troponin elevations something that's going to be from a primary cardiovascular etiology, or is this secondary to something else going on? So in terms of myocardial injury, as you can imagine, there's high variability in the actual definition, and that's what contributes to, kind of a higher range or an increased range of incidence from 7 to about 40%. Patients do present with atypical symptoms. Some may or may not have chest pain. Some may or may not have cardiovascular disease. We'd also see that there could be myocardial and end organ damage that's even occurring more than 2 weeks out after the initial onset of symptoms. We do see that myocardial injury, though, is associated with an increased risk of in-hospital complications and mortality, which is quite interesting and I think anticipated as well. And these troponin elevations seem to correlate to higher levels of inflammation or inflammatory biomarkers that we routinely measure, such as ferritin, interleukin-6, or C-reactive protein and D-dimer. And it may also be correlating to the severity of actually underlying respiratory illness. So whether myocardial injury is truly a marker of disease severity or a direct correlate to COVID morbidity and mortality still remains unclear. There was actually a study coming out of New York City. It was a multi-center retrospective analysis taking a look at troponin elevations and mortality, and it evaluated nearly 3,000 patients, of which more than a third had myocardial injury measured by an elevated troponin I on presentation. And after they actually adjusted for baseline confounders, they were able to correlate that this troponin elevation seemed to be associated with an increased risk of in-hospital mortality. And those who were coming in with myocardial injury are what we would anticipate. So they tended to be older with more comorbidities. And interestingly, only about 30% had a history of coronary artery disease. And so here you can see some of those studies. Dr. Anulala is out of Mount Sinai, actually. She was able to also show the incidence in this cohort of 2,700 individuals. And you can see here that those who actually had elevated troponin levels, that did correlate it to an increased risk of in-hospital mortality after a multivariable adjustment. So how do we risk stratify? So I always found this kind of 2x2 plot quite helpful. It basically categorizes COVID by risk. So you can see here on the horizontal axis, we've got the low risk and the high risk groups. And then it also correlates risk to low, intermediate, and high risk of ACS or venous thromboembolic events. And so if we just even look at our low profile, so low risk of COVID and low risk of any sort of thrombotic event in ACS, there we typically will look to do guideline-directed medical therapy per our ACS algorithm. And we'll really kind of favor any sort of invasive strategy if we see recurrent persistent symptoms or perhaps decompensation or quote unquote, even heart failure symptomatology. From a kind of thromboembolic perspective, those individuals who have low risk of COVID or low risk COVID-19, I should say, as well as low risk of any thrombotic event, again, we typically will look at mainstay anticoagulant therapy, really not pursuing any sort of invasive strategy. And then if we look at our higher risk individuals, and I'll take you over to our kind of quote unquote high, so high COVID-19 risk as well as high risk of ACS or VTE, that's typically where we're going to look towards urgent and emergent angiography and perhaps an intervention, whether it be surgically or percutaneously. These are the patients who are probably going to be hemodynamically unstable, requiring some sort of either cardiac or cardiopulmonary support. And then from a kind of thromboembolic perspective, these are going to be the individuals where we consider things like thrombectomy, whether or not we're going to need longitudinal anticoagulation. And again, this is kind of our hemodynamically unstable cohort. So this can be helpful when you're trying to determine, does my patient need to be in prophylactic anticoagulation? Does my patient's cardiovascular care need to be escalated to a point where we're considering invasive strategies? Or is this a patient who's low risk, whose risk of kind of mortality from a cardiovascular perspective can be managed medically? And then finally, arrhythmias. So like I mentioned earlier on, we do see more arrhythmias with cardiovascular impacts of COVID-19. Obviously, a substantial increase in individuals who come in with some form of myocardial injury, whether it be a type 1 MI, so acute plaque rupture, or type 2, our supply-demand mismatch. There are some additional mechanisms that have been thought about with respect to arrhythmogenicity, such as electrical instability from QT prolongation, which we can see, kind of across the spectrum, either coming from metabolic derangements that can be seen in people who have acute sepsis, like hypokalemia, hypomagnesemia, or whether it be medication related. So, for instance, back in the, quote unquote day of early pandemic, we saw chloroquine, hydroxychloroquine, azithromycin being used, and those were in situations where we really had to, follow them electrically to see if these were going to be individuals where we see some sort of electrical decompensation. And then hyperinflammation in itself, as well as cytokine upregulation, can propagate arrhythmias that can also lead to prolongation of ventricular activation, ventricular action potential duration, as well as sympathetic hyperactivation. So surges in catecholamines can always lead to increase in erythrogenicity. So we've kind of talked a little bit about acute cardiovascular complications of COVID-19 and what to look for when we're thinking about myocardial injury, perhaps myocardial infarct, and even much less now, actually, myocarditis. And now I kind of want to take you through our post-COVID syndrome or post-acute sequelae of SARS-CoV-2 and what we're seeing from a cardiovascular perspective. I think this diagram does a wonderful job in kind of summarizing just the wide gamut of symptoms that we see in these patients, as well as the multi-systemic symptoms that we see. So I think what you'll notice through this talk is, kind of a question that I always have in my mind of how much these symptoms that seem to be cardiac are truly cardiac. This also shows how we define post-acute sequelae of SARS-CoV-2 or long COVID. And the definition varies depending upon kind of the organization or the center that has created the definition. So here in the United States, we are basically going by the CDC definition of anyone who's got persistent symptoms 4 weeks or more out from acute COVID-19 infection would qualify as someone with post-COVID-19 post-COVID syndrome. If you look at the UK, as well as the World Health Organization, they'll provide a definition where anyone who has symptoms 3 months out from their acute COVID-19 infection has post-COVID syndrome. And so here you can see SARS-CoV-2 exposure early on, and the viral peak or the peak in viral load, and then the gradual waning of viral load taking us through into week 4, where we really don't see much viral load present, but now we're seeing the manifestation of these symptoms in patients who are PCR negative. Most commonly, we see fatigue. We do see myalgias, arthralgias. From a pulmonary perspective, there are individuals who have persistent shortness of breath. There's even individuals who have had persistent oxygen requirements, albeit I see this more so in my individuals who had high-risk COVID infection with cardiopulmonary complications. Anxiety, depression, sleep disturbances, most commonly insomnia, even PTSD in individuals who've been dealing with lingering persistent post-COVID symptoms for quite some time, brain fog, headaches from a cardiovascular perspective, palpitations, chest pain, exertional intolerance, inappropriate tachycardias, perhaps some arrhythmogenicity, thromboembolic phenomenon, hair loss is also another common one, rashes, neuropathy. These are probably the most common symptoms that we've seen associated with post-COVID syndrome. So you can kind of see, if we're seeing a multi-systemic picture in these individuals, then it does require a team to manage that patient. We have a pulmonary team, cardiac team, neuropsychiatry. I think these individuals, and it's quite interesting to see the involvement of mental health issues, whether it be anxiety, depression, PTSD, in this cohort. I'm really interested to see kind of prospectively how many of these individuals have required some form of therapy or medical or medical intervention. Primary care really is at the mainstay of coordinating all of our consultants. And then hematology, vascular medicine, kind of from a thromboembolic perspective is always very helpful. And this is where you can see kind of having a cohort of consultants and specialists coming together to create kind of a multi-systemic COVID clinic or post-COVID clinic would be entirely helpful for these patients who are coming in with just so many different complaints. So what's causing these post-COVID syndrome symptoms? So we have potential mechanisms, but unfortunately, we do not have the true kind of proven pathophysiologic mechanism that is precipitating all of these symptoms. So with respect to chronic fatigue, which is probably one of the #1 things I see in my own clinic, the suspicion is that this may be coming from chronic inflammation, but we haven't really seen any association between pro-inflammatory markers and long-term fatigue. There's really only been one study here. I have some patients, and again, I speak anecdotally because we just don't have the data and the studies to show a direct correlation, but I have some patients in my clinic who may have elevations in pro-inflammatory markers like ferritin and D-dimer that persist, but things like a C-reactive protein or erythrocyte sedimentation rate are otherwise normal. And so it's very hard to kind of make a direct association with those two at this point. There may be some congestion of the lymphatic system, and that could be caused by the olfactory neuron damage, which increases the resistance to cerebrospinal fluid drainage through our cribriform plate, and that can lead to an increase in toxins within the central nervous system. There's a possibility for cell-mediated immune responses, and that can lead to some hypometabolic state within our frontal lobe and cerebellum. We may even have direct SARS-CoV-2 infection of skeletal muscle, which then leads to this kind of persistent weakness, perhaps myalgias, negative psychosocial and social factors. We should always just not ignore the environmental triggers that could lead to chronic fatigue. And then there's this question of whether or not there's overlap with myalgic encephalomyelitis or chronic fatigue syndrome. Interestingly enough, I think over the last 2 years, there's been an increase in the number of individuals who've been diagnosed with ME/CFS, and it's hard to say, whether or not COVID-19 augments and brings about this syndrome, whether or not they're completely delineated, or because people are coming in now with chronic fatigue pictures, whether we are now actually looking for ME/CFS more. And that's a very challenging disease process to treat. From a cardiovascular perspective, so a lot of those symptoms that I mentioned could be seen as cardiovascular red flags, which is why, when these patients are coming into my clinic, I don't completely say you have post-COVID syndrome, I don't need to do any cardiac testing. I really do my due diligence to make sure that we're not missing common things like cardiovascular disease when patients are presenting with symptoms post-COVID. So most commonly, we have seen exertional intolerance. So even just putting on a sweater could be very taxing, or walking from the kitchen to a nearby bathroom can be taxing. Can be limited by palpitations or lightheadedness or feeling like you're going to pass out. Tachycardia is quite common and oftentimes very discordant to exertional intensity. We even see postural tachycardia, inappropriate sinus tachycardia. A lot of patients come in with chest pain syndromes that seemingly may be atypical or non-typical. Or atypical or typical, meaning, either not related to exertion or perhaps brought on by exertion. We see positional lightheadedness, pre-syncope, syncope, and then I've even seen hypertensive scenarios. A number of my patients will come in with de novo hypertension after COVID-19 infection and previously had low or normal blood pressures. So what do I do in these individuals? Like I mentioned already, I really do try to do my due diligence in providing a comprehensive cardiac workup so that we're not missing common cardiovascular abnormalities like coronary artery disease or a cardiomyopathy or perhaps electrical instability. So for chest pain, we typically will start with our mainstay electrocardiogram as well as an echocardiogram to look at structural and functional abnormalities. I will typically include labs such as a troponin, D-dimer, ESR, and CRP, again, looking to see if they have any sort of pro-inflammatory state persisting. And then the troponin I will still continue to use to help me determine whether or not this may be an individual where I have to worry about myocardial or pericardial inflammation. And then depending upon my suspicion, I may or may not include stress testing. Initially with the pandemic, I think we had a very low threshold to utilize cardiac MRI, again, because our suspicion for myocarditis was much higher than what it is now. So I don't necessarily utilize MRI unless I am suspicious of active inflammation within the myocardium or the pericardium. So if I see any sort of abnormalities on echo, if I have persistent chest pain syndromes versus an exertional intolerance that I cannot otherwise explain, I may reach for the MRI. With respect to shortness of breath, it's quite similar testing, albeit, if I'm not suspicious from a cardiac perspective, I will then reach out to my pulmonary colleagues and look to do things like pulmonary function tests, perhaps CT scans to look for, any sort of ongoing bronchial processes and whatnot. For exertional intolerance, orthostasis, lightheadedness, palpitations, inappropriate tachycardia, and syncope, these are situations where I'll consider adding on some sort of ambulatory rhythm monitor, so a Zio monitor, for instance, or an event monitor. And then I may also consider doing tilt table testing, which can be very useful in patients who are coming in with either postural symptoms, pre-syncope, syncope, and we're trying to delineate what the cause of that syncope may be. Vasovagal being the most common, something that we can usually clinically diagnose versus needing tilt table testing. And then looking at other things like orthostatic hypotension, orthostasis, and then of course postural orthostatic tachycardia syndrome. Of course, finally, autonomic dysfunction. So that brings about, kind of this question about postural orthostatic tachycardia syndrome, and autonomic dysfunction within our long COVID population. So one of the first case series that was published was one coming out of Sweden looking at long haul post-COVID symptoms, any sort of correlation with POTS as perhaps being the precipitant of these symptoms. And they looked at 3 individuals who were diagnosed with POTS about 3 months out after acute infection. And I include the diagnostic criteria of POTS here just because I think, oftentimes we think, okay, maybe a 10 to 20 beats per minute increase in heart rate with just standing is a diagnosis of POTS, but that's not necessarily the case. We typically will see heart rate escalation of at least 30 beats per minute, but with respect to blood pressure really should either stay the same or go up. It really doesn't go down. That would be more suggestive of orthostasis. And so they provided treatment strategies that were predominantly supported: compression stockings, hydration, electrolyte repletion. They did try to utilize medications to see if symptoms improved. Common medications we use for POTS include propranolol, ivabradine, which is generally indicated for heart failure patients who are intolerant of medications that may reduce blood pressure. Ivabradine, fortunately, is just kind of purely reduces heart rate. And then pyridostigmine, which has been shown to help with POTS symptoms in as many as 30% of patients. Here at the clinic, we actually did our own look at POTS and autonomic dysfunction in athletes and active individuals, I should say. We had a number of individuals who I've seen now kind of through the course of the pandemic coming in with post-COVID-like symptoms. And we were able to isolate about 7 young active individuals, of which 5 were athletes, who had symptoms of postural orthostatic tachycardia-like syndrome. In these individuals, you can see here in the bottom, just from baseline compared to escalated heart rate, you can see that all these individuals had higher heart rates well above tachycardia. So somewhere between 100 to 150 beats per minute after having acute COVID infection. And from the symptomatology perspective, all of them came in with palpitations. Most of them had shortness of breath. And then you can see kind of this array of multisystemic symptoms. So GI symptoms, lightheadedness, weakness, anxiety, and then even a couple who came in with syncope as a presenting symptom. And so when we think about autonomic dysregulation or dysfunction, it really is a multisystemic process, not so much just delineated completely upon, passing out or heart rate dysregulation. In these individuals, we predominantly treated them, again, with supportive therapies, aggressive hydration, electrolyte repletion, utilizing as well as compression. And then medications included metoprolol, ivabradine, even midodrine for those who had lower blood pressures. Anecdotally, we actually did try intravenous immunoglobulin therapy in 3 patients. One person had complete resolution of her post-COVID symptoms after 2 weeks. The other 2, one person had no change, and then the other person had maybe some improvement in symptoms over the first couple of days, and then it kind of petered out. Intravenous immunoglobulin therapy is quite expensive therapy. We do utilize it in our POTS cohorts with respect to those who have COVID-19 or post-COVID syndrome. We haven't actually clearly been able to show that that's could be a mainstay therapy that provides relief in most patients. So with respect to autonomic dysfunction, I think, I probably started to see it maybe early on in September, October 2020, and then we were actually able to come out with the name of post-COVID syndrome, followed by, some correlation to autonomic dysfunction or dysregulation. And so the American Autonomic Society actually put out a statement about long COVID postural tachycardia syndrome. And here you can see some of those symptoms that parallel to what we see with autonomic dysfunction: this breathlessness, palpitations, brain fog, sleep disturbance, orthostatic intolerance, even cognitive impairment, which was just quite challenging in a lot of my collegiate athletes who are trying to study, but just are unable to do so. Anxiety, depression, skin rashes, sore throat. So again, multisystemic. And if you look at long COVID POTS, we would see these long COVID symptoms and then an exacerbation of orthostatic tachycardia, as we had defined previously. So, I kind of gave you my own format of what we've been doing from an algorithmic standpoint, looking at cardiovascular symptoms in our post-COVID patients. And this is kind of how we have been kind of putting patients through our clinics with respect to symptoms that they may present with. So we have our conglomerate of symptoms that we discussed that may suggest some sort of cardiovascular etiology. And we go ahead and order the testing that we deem is appropriate. And then here at Cleveland Clinic, we're able to refer them to specialty clinics within just our own cardiovascular department, whether it be heart failure perhaps or a myocarditis clinic, whether it be to our pulmonary colleagues or vascular medicine colleagues. For those who have some evidence of electrical instability or arrhythmogenicity, we'll refer them to our electrophysiology clinic. And then, here we're fortunate enough to have 2 electrophysiologists who direct our syncope clinic, who have also been managing a lot of our patients who've been coming in with post-COVID autonomic dysfunction. So we actually do have a team of teams here, and we also include our neurologists who have been quite impressive and just incredibly helpful in kind of delineating autonomic dysfunction related to COVID. So as a sports cardiologist, I have seen a number of athletes kind of from, collegiate, even high school athletes, all the way through to elderly athletes or masters athletes who've come in with post-COVID syndrome. And it can be quite restrictive, especially in our younger athletes. I have a number of high school athletes who have been trying to get scouted for collegiate sports participation, and having post-COVID syndrome can really put a damper on access to scholarship, because you're just not able to perform at the level that you previously were able to do so. And so in these individuals, I'm very aggressive in terms of ensuring that there is no true cardiopulmonary etiology outside of post-COVID syndrome that could be precipitating their symptoms. For those who come in with exertional intolerance and have negative cardiac testing, we typically return those athletes to sport via a graded protocol. And fortunately, as the pandemic has proceeded, we've been able to limit the amount of time that they stay away from sport, and therefore limited the confounder of deconditioning. In individuals who have presented with tachycardia, and I have a number of individuals who have come in with baseline heart rates pre-COVID of maybe 40 to 50 beats per minute, which is what I expect for my athletes, now coming in with baseline heart rates of 90s to 100s. We definitely always want to exclude any sort of arrhythmogenicity with rhythm monitors, but I can typically get them back to sport, and over time that exercise helps with heart rate regulation. And we see that kind of through the gamut. We treat autonomic dysfunction quite similarly to how we treat post-concussive syndrome. In both of those syndromes, we see heart rate dysregulation, even blood pressure dysregulation, and exercise is actually a mainstay in rebalancing your sympathetic and your parasympathetic symptoms, essentially improving heart rate variability. So what I'm learning through this process, and what we are learning through our research, is that exercise truly is the mainstay of trying to manage post-COVID syndrome symptoms. In our individuals with chest pain, albeit while viral myocarditis is quite rare, again, in about 0.6 to 0.7% of our collegiate and professional athletes that we have studied thus far, I will still utilize cardiac MRI if I do have heightened suspicion of myocarditis, meaning I see evidence of inflammation, perhaps troponin elevation, or some sort of structural abnormality on echo. I will go ahead and proceed with an MRI. Now, if myocarditis is present, we typically will follow our American College of Cardiology, American Heart Association guidelines of having these individuals kind of participate in low intensity activity, walking, yoga, things along those lines for at least 3 months. And the reason for that is because these individuals are at greater risk for sudden cardiac death due to the propensity for ventricular arrhythmias from active inflammation. So we want that inflammation to go down before we actually start to provide a stimulus, electrical stimulus, a burst in catecholamines with exercise. With respect to pleuritic pain, we always want to exclude any sort of pulmonary embolism. So that's always important to make sure that we check for. And then finally, I think lightheadedness, orthostasis, syncope have been quite common among athletes. And, the interesting thing is, athletes tend to have heightened vagal tone. They have great heart rate variability to begin with. And I do wonder whether or not this heightened vagal tone may increase their susceptibility to more lightheadedness from a post-COVID standpoint. Like I mentioned, I think POTS has become something that I've been diagnosing more frequently, autonomic dysregulation as well. And we're fortunate enough to have a neuromuscular clinic here at Cleveland Clinic, where these individuals do undergo autonomic testing, whether it be with skin biopsy or whether it be with other testing like juicer testing and whatnot. And then finally, hypertension. So I alluded to the fact that I have a number of individuals who come in with now aggravated blood pressure, even as high as 140s to 160s. I've seen this even in my younger athletes, interestingly enough, and I do choose to treat them through these hypertensive episodes, noting that over several months of time, blood pressure essentially gets to a low state, and that's where we start to peel off medications. That typically correlates to their heart rate regulation improving. And so that's when I can kind of get, and understanding that it seems like their post-COVID symptoms are dissipating. So treatment strategies, I think the biggest takeaway here is exercise retraining is incredibly important, not just for athletes, but for even our sedentary individuals with post-COVID syndrome. We actually have a PASC cardiac rehab program here as well, where we provide exercise prescriptions to help retrain heart rate. And then medications for arrhythmias, we'll typically use beta blockers. I have a number of patients who have had increased sensitivity to PVCs, even if their PVC burden is quite low. And beta blockers help with symptom regulation. Ivabradine, again, is another medication purely for heart rate control. And then for POTS, we have our acetylcholinesterase inhibitors. We do have some neuropathic medications. Our anticonvulsants, gabapentin is one that I've utilized in individuals and anecdotally has seen some improvement in chest pain syndrome. So perhaps there is some chest wall neuropathy that is precipitated by post-COVID syndrome. Beta blockers, again, can be helpful. And then chronic myocarditis is really dependent upon the systolic function of the heart. So I think the biggest thing here is that we don't treat myocarditis with steroids. We don't treat myocarditis similar to pericarditis. To really treat active myocardial inflammation requires rest. We want that inflammation to go away. We can measure that inflammation in an MRI, and oftentimes I will repeat a cardiac MRI about 3 months post initial insult to make sure there's no inflammation. We have to always make sure we incorporate an exam of mental health. Cognitive behavioral therapy and group therapy is incredibly helpful in these individuals. So this is kind of what our clinical cardiology care path looks like at Cleveland Clinic. We typically have a referral base, whether it be a direct referral or from another provider. Our intake from a cardiovascular perspective will always go from a history and exam to downstream testing, whether it be imaging as simple as echocardiography or more complex with cardiac MRI or stress testing or the monitoring autonomic testing. And then finally, with respect to our specialty clinic, we do have a recover clinic here for non-cardiac subspecialty referrals, and then we can always do follow-up with a physician extender or a direct physician. And I just wanted to put up a slide just to highlight our recover clinic. You know, we have a magnanimous wait list. We've seen a number of patients, and it just allows for us to, you know, kind of get a sense of similarities among patients so that we can learn to treat them better and perhaps really identify the mechanism behind post-COVID syndrome. Finally, in our last couple of minutes together, I want to talk about the impact of telehealth and on our cardiovascular care, particularly in our post-COVID patients. So it's quite interesting. You know, I think initially when I started working here at Cleveland Clinic, we never really focused too much on virtual visits. I honestly can't remember how many I may have done pre-pandemic. But in March 2020, as you may all remember, at least here at the clinic, you know, we really stopped seeing many patients in our offices and were completely reliant upon virtual visits. And that's when we started to see the exponential increase. 2020 to 2021, as we started to reopen our doors, we had a blend of virtual visits and in-office visits if they were necessary. And now to present day, you know, it's really not uncommon for many of us to have a number of virtual visits that we continue to include, even though, you know, our clinic doors are wide open for in-office visits. And these virtual visits are not necessarily one-to-one. They definitely can incorporate shared medical appointments, but definitely, you know, probably single patient visits are the most common. And then here, you know, I just wanted to kind of show you, you know, what our media outlets have been saying through the course of the last couple of years with respect to telehealth being incorporated amidst the pandemic and managing our COVID and post-COVID syndrome patients. And so, you know, there are some who do think that our medical system is improving because of the access to virtual care. I think doctors and patients both would say that, you know, at least allows for longitudinal assessment and evaluation of care, especially when patients are just not able to come in. And then there's definitely a group of individuals who feel that telemedicine is maybe overutilized, and perhaps, you know, we're not doing enough of an examination in the office, and, you know, maybe we're missing certain diagnoses, or, you know, we're missing that face-to-face interaction where, you know, direct visualization and kind of seeing how someone gesticulates provides us greater insight into what actually needs to be managed. And then, you know, finally here, I think rural America, you know, particularly those who have access, you know, can really utilize and benefit from telehealth as well. So we have several types of telehealth here. You know, we have both synchronous and asynchronous. And synchronous is, you know, kind of what we think about when we think virtual visits, direct real-time patient-provider interaction. And then asynchronous is something that many of us are very familiar with, the emails with our patients or the MyCharts with our patients, depending upon your EMR, instructions, image review, result review. And then, of course, we have remote patient monitoring. So from a cardiovascular perspective, this is where, you know, we think about live device interrogations, or remote device interrogations being sent over to us, perhaps remote ambulatory rhythm monitor data being sent over to us, glucose meters, blood pressure monitors, oximeters, and then for heart failure patients, CardioMEMS monitoring, so monitoring pulmonary pressures and whatnot. So there's definitely incredible advantages that I think many, if not all of us, have noticed with virtual visits. And the number one being increased access. There was a huge period of time, I think personally, between March, May, June, March to fall of 2020, where losing that access to patients who require critical follow-up, it was quite challenging and definitely, making us quite concerned about, are we able to actually take care of patients who need more comprehensive care at frequent doses. So I think that's probably the number one benefit of virtual visits. Offline communication can oftentimes provide more efficient care. Now, how many of us have had patients come in with one or two questions and they didn't necessarily need to come in for a visit for that, and we can be very efficient with our time and their time, giving them kind of more streamlined answers in a shorter, less timely format. And then I think shared medical appointments. So we talked a lot about post-COVID syndrome patients. You can imagine that those who are combating ongoing fatigue, exertional intolerance, feeling like they've done a complete 180 from what life may have been like pre-COVID. These individuals need a lot of mental health support, and that's where shared medical appointments can come in and be quite useful. Seeing and sitting with others in a virtual room who are experiencing the same thing you are feeling does provide some level of comfort and reassurance that you are not alone. And I think the pandemic itself was so isolating that now bringing a forum where individuals can, quote unquote, sit together can again provide a little bit of reassurance, support, and perhaps help with the mental health struggles that people are experiencing. There are, of course, disadvantages. There may be lack of health equity, particularly if patients lack resources for telehealth. And so, I always kind of think about those patients who may be in rural territories or individuals who do require aggressive cardiovascular care, but just don't have access to internet or access to a phone or access to a computer. We're still missing those individuals. We can't do a physical exam over the phone, and even over the computer, and even pictures through a virtual visit may not do justice. Asking a patient from a cardio perspective to, poke their leg to see if they have pigment edema is not quite the same as doing that exam on your own. And then reimbursement, obviously from an administrative level, is something to consider. Purposes of telehealth, so clinical care is obviously the number one reason why we've been doing it. But there's various reasons to do telehealth. I think we've also utilized it for research. We've utilized it for contact tracing, for healthcare worker well-being, apart from just patient care. Here, we've noticed that predominant specialties tend to be internal medicine, primary care, but we do see it quite useful in preventive medicine. That takes me to shared medical appointments, talking through diabetes management, cardiac risk management, whether it be primary or secondary prevention, and then psychiatry as well, surgery and neurology. From a cardiovascular perspective, I still utilize virtual visits for symptom follow-up. I think it's such an incredible tool to do so. Medication, education, titration that oftentimes don't require an office visit, blood pressure management as well, and then counseling. I love face-to-face counseling, but I think even face-to-face on some sort of Zoom platform or not can be an incredibly useful modality for both patient and provider. And then as a sports cardiologist, I have a lot of younger individuals who want their parents to be involved on their visit, and perhaps parents are in one location and the student athlete is in another. And so the virtual visit provides, for me personally, a format where I can have everybody in one space and we can communicate effectively. And then from a post-COVID perspective, I think, what I want to highlight here are the shared medical appointments. I think our neurologist, our neuromuscular department does this really well, particularly for individuals who have POTS or autonomic dysfunction. And then finally, psychosocial support. I think this is an area that, I personally really try to highlight in my visits, whether they be virtual or face-to-face. But I do bring that up on again and again, because I think even from a primary care perspective, mental health is something that we're going to continue to need to address even in the post-pandemic state. So what are our next steps? So I think first and foremost, we need to really identify the actual mechanisms of cardiac involvement with acute and chronic COVID infection. And unfortunately, we're just not able to do so at this time, apart from just postulating mechanisms based upon what we know about viral mediation with other viruses akin to SARS-CoV-2. It's also very important to define the mechanism of post-COVID syndrome, because it would be great to develop that magic bullet, that strategy to just provide a treatment for patients who are afflicted with this for months, even years to end now. And then I think it's important to expand telehealth beyond the pandemic and work towards health equity. I think developing access points for patients who may not have a phone, who may not have a computer, but perhaps there's an access site where they're able to develop this virtual connection with their provider would be the next step. So just to summarize, our suspected mechanisms for cardiovascular impact of SARS-CoV-2 includes a cytokine storm that precipitates endotheliolitis or endothelial dysfunction, micro and macrovascular thrombosis, and multi-organ failure. It's very important to risk stratify by COVID severity and the severity of cardiovascular comorbidities to understand those who are going to be at increased risk of myocardial injury, whether it be from type 1 or type 2 MI, as well as thromboembolic phenomenon. And then the exact mechanism for post-acute sequelae of SARS-CoV-2 is very unclear, though it is predicated on probable hyperinflammation, lymphatic congestion, some cell-mediated immune responses or autoantibody involvement, maybe even direct viral infection of the skeletal muscle. I think more and more so, in my mind, cardiovascular symptoms for post-acute or post-COVID infections seem to correlate to autonomic dysfunction, and so we personally continue to investigate that here. And then finally, telehealth utilization for post-COVID has really provided a means for us to have close clinic follow-up, even if it be more so for mental and psychosocial support than perhaps physical. And that allows for us to also just increase our ability to be efficient with medical management and counseling. So thank you so much. And with that, I guess we'll open it up to questions. Dr. Zack, I'll root back to you.
Thank you, Dr. Singh. I know we are running a little bit short on time today, but I do want to make sure that we address the few questions that we do have. And if other folks have questions, we're happy to get you answers, even if we can't address them all live in this moment. Do you have any comparisons between patients who took the vaccine and those who did not in terms of long COVID implications?
Yeah, so this is going to be kind of anecdotal. What we know, at least from large populations of those who have taken the vaccine, the benefit of the vaccination outweighs any risk of developing post-COVID syndrome. I have not seen a direct cause and association. Now, I have a few patients who have said that they've developed post-COVID-like symptoms about 4 to 6 weeks after initial vaccination, even if they never had acute COVID themselves, but there has been no direct mechanism identified between the vaccine actually propagating post-COVID. And in those 2 or 3 individuals, again, I speak just from personal experience, those post-COVID-like symptoms did eventually dissipate.
Do exercise recommendations for post-COVID include supine versus upright exercise?
Yeah, that's a great question. So in my individuals who do have some element of autonomic dysfunction or who are orthostatic or have a diagnosis of POTS, I definitely encourage them to consider recumbent positions when they start to exercise, because you can imagine walking can be quite challenging if you feel like you're going to be passing out. So very similar. So the things that I reach for a recumbent bike, I also reach for the rower. I think, that seated position still allows for kind of a nice full body workout for them. They can stop, they can pause. And I think that gives them a little more leniency than perhaps the recumbent bike. And I think more people tend to have access to that. If they can tolerate some sort of standing, even if it be for a couple minutes here and there, then we can consider non-supine modalities for exercise. But yeah, recumbent is a great strategy.
Thank you so much for this great talk today, Dr. Singh. There was one other question about other recover type clinics statewide for those patients with cardiovascular or other comorbidities. We will try to put together a list of those for you, for all of those of you who might want that, and we'll put it on our resource page for cardio. So that's something that we'll get up there as soon as possible. Thank you so much, Dr. Singh.
Thank you so much for having me.
Great. Thank you, Dr. Singh, so much for this wonderful presentation. Thank you, Dr. Zack, for moderating. Just a quick few wrap-up things for everyone. Just if you joined late, if you want CME, you do need to register for that. So use the QR code or URL if you haven't registered and want CME. And then the next thing is that when we close, you'll see a survey pop up. We'd love your feedback so that we can make these webinars as useful to you as possible. And then I think the last two more slides. Just one is just letting you know about our upcoming Echo series, where you can get feedback on cases that you share with experts. And this will be around innovations in diabetes and cardiovascular health. So that's starting January 12th to March 30th. And you can see more information about that on our website. And lastly, again, just any other resources, we invite you to visit our cardio.org. If you want to sign up for our monthly newsletter, you can subscribe there, and you can follow us on social media. So thank you again to our wonderful presenter, Dr. Singh, to Dr. Zack for moderating, and to all of you for joining with us today. We look forward to chatting with many of you in the future. Thank you.